everyone. I am Hiba, and Xiomara and I are psychiatry residents. So I am in my 4th year, which is my final year of psychiatry residency, and I will have Xiomara introduce herself in just a minute. We are going to be presenting a lot. So today we will be covering on like depression, anxiety, suicide, and social determinants of mental health, and it's a lot. So we'll try to weave in everything as we go with this. So I guess whatever we talk about, I think social determinants of mental health are going to be part of it. I am also a part of clinician educator track, and so I love teaching. And then I can then have Xiomara introduce herself. I'm so excited.
Hi guys, as Hiba said, my name is Xiomara Nieves. I'm a 2nd year resident in the Duke psychiatry program, and I'm very interested in sharing my knowledge with you guys about anxiety and its cousin depression. So let's get started.
All right. Yes, I'm still kind of trying to navigate the Zoom thing. So my camera is here, but I'm looking here because you guys are there. So I don't know what it is. So this is our workshop number 3, and this is gonna be, as I said, mainly covering depression, anxiety, and suicide, and social determinants of mental health. I'm going to the 2nd slide, where we are just gonna be outlining some of the broad learning objectives that we will be covering today. So the broad objectives are gonna be us talking a lot about mental disorders and the depression and anxiety being really the bread and butter of mental health disorders. And we'll be talking about the suicide prevention and a little bit about suicide, so introducing the concepts of suicide, a little bit about assessment, and a little bit about prevention and the role of mental health advocates in suicide crisis. So we'll be then talking about the roles of the advocates, the boundaries, the responsibilities, the limitations, and so forth. As we go into some of the nitty-gritty details about depression, we'll try to understand what depression is to different people, as well as some of the broad symptoms of depression, as well as the very unknown common treatments of depression. And then we'll talk a little bit about the prevalence and the social determinants of like mental health when sort of like weaving it into depression. And then the same as Xiomara will be talking about anxiety. And again, the neuroscience, that will be very exciting, talking about the neuroscience of anxiety. And that would be at the later part of our slides. So those are some of the things that we will be talking about today. Xiomara, do you want to add something that I have missed?
I think we'll be having some groups, some breakout rooms, discussing cases and discussing everyone's point of view, since this is can be taken as subjective, and we're trying to establish a standard and a pattern that will, as our goal to teach you.
Yeah. Thanks for bringing this up. Oh, I love the heart. Thanks for bringing this up. And so there's going to be a lot of participation, and it will be very interactive and collaborative. That's our hope, is to make it as collaborative and interactive as possible. All right, I'm going to the next slide. All righty. So first of all is like the role of mental health care team. So ideally, our patients who have mental health disorders ranging from depression, anxiety, to a very severe mental illness like psychosis and bipolar disorder. Ideally, in ideal world, most of these patients would have psychiatrists, psychologists, and social workers, and care management, care coordinators. And so the idea here is to kind of just highlight the responsibilities and sort of like the broad roles of each one of these mental health professionals. So a psychiatrist or a provider, so it could be an advanced provider, an advanced practitioner like NPs or physician assistant, can also be primary care provider who who usually, because 60% to, because 70% of antidepressants are actually given by primary care providers in the United States. And so primary care providers could also be part of like the MD providers providing treatment, medication management for depression and other mental health disorders. And the psychiatrists are basically trained. They are physicians. They have earned their MD degree, and then they have like 4 years of training and even more in psychiatry to kind of treat mental health illnesses. And so that is basically sort of like the broader role is for them to provide medication or pharmacological management of mental health disorders. The psychologists or clinical social workers are sort of like, laymen in sort of like lingo, they are therapists. So they can be PhDs, they can be PsyDs, they can be licensed clinician, licensed clinical social workers, and MSW, which are also masters in social work. So they're sort of like are there that provide psychosocial support, psychosocial functioning, and they sort of like they improve psychosocial functioning through non-pharmacological interventions, which could be providing psychotherapy or providing individual one-on-one therapy, group therapy, community supports, family therapy, and so forth. So their main role is to provide non-pharmacological management through psychotherapeutical interventions. Care coordinator is like a term that has been, it is sort of like a care management. Their role is coming up more and more, and hopefully we'll have more care management teams and care coordinator as the Medicaid expands. And so there will be some expansion, and in future years, we'll see that patients who have like severe mental health illness will have care coordinators or care management team, and their primary role will be to collaborate with the mental health care providers or their providers. It could be their medical providers or mental health care providers to coordinate with medical staff and the patients. So they'll be like the liaison. They'll be liaisoning. They'll be helping coordinate patient care appointments and maintain a treatment plan. So their role is going to be very pivotal in as especially now as there are some advancements that will be happening, hopefully, as we advance into more value-based care in coming years. Any questions regarding this? So moving on to depression and what really is depression.
There is one question.
Yeah, yes, go ahead.
Fiona asked, does anyone know if there's a certification or program to be a care coordinator?
So I believe, and I don't know a lot about it, but I do believe that there are some programs that are happening where some LMEs, which are basically sort of like the management team, which are like the Medicare management teams, are organizing, like the Alliance Behavioral Health and Cardinal Innovations, are sort of like these LMEs, which are sort of like the local private Medicaid agencies that do have care coordinator programs. And as it advances, I think that more and more teams more and more mental health centers will adopt their roles and will kind of start including care management. So more will come up in future years. But at this point, my understanding is that Cardinal Innovations and Alliance Behavioral Health may have some opportunities for care coordination. So this is a question that we thought that we would bring up as we talk about depression. I just wanted to get a sense of like, what do you guys think? As we always approach, even like when we are doing our assessments and a patient with depression comes to our clinic, we always ask them, is like, depression is different for different people. people? What is it like for you? And so if we just wanted to open it up for you guys, what do you think? What does depression feel like? Oh, I have these
And while
great
we're waiting for that,
responses.
there was one person who also asked, where do qualified mental health professionals fit within the hierarchy?
Qualified mental health professionals fit
Where
within the, let me read the question. So I wonder if like qualified mental health professional is like a term, or is it like a broad category of like qualified mental health professional, like is a very broad category of like behavioral health professional. So it's basically a broad term and it includes a lot. It can include anywhere from like psychiatrist to psychiatric nurse practitioner, psychiatric PA, to all the way to psychologists, clinician, clinical social workers, and psychotherapists, if I'm not wrong. Xiomara, do you?
Yes, I would like to add that maybe, I can understand why it is being seen as a hierarchy, but I honestly feel like it's literally a teamwork, because there's many things that as physicians we don't know how to do versus a social worker or a case manager. Also nurses, we don't deal with like, either handling the medications to patients or handling with their behaviors. We just know what they do, read the reports, and like prescribe. So everyone, I think, has their role, and to see it as a hierarchy, I think it will be kind of not justice, but just.
You're right, and that's such a great point, Xiomara, and thanks for bringing this up, Riley. This is really not like a hierarchical, but again, there are certain responsibilities that are sort of like overseen and supervised by like psychiatrists. So like a physician assistant, a nurse practitioner to sort of like manage care and then like independently, and yet they need some supervision from like psychiatrists, and that's sort of like a different level. That's sort of like state dependent or federal dependent. But you're right, it's such an interdisciplinary concept in that a psychiatrist is like cannot do a certain thing that a social worker can, and so forth. Like a psychologist can do something that a psychiatrist cannot, and that's why I brought up this slide, because each one has such a unique role, and then it's just the best when they're sort of like working in collaboration is like really optimum for patient care. That's a great question. So that's just wow, I'm getting these responses. That's amazing. Like, yeah, I want to get out of bed, cloud, and motivated. Sadness. Like exactly. Like these are so like hopelessness and stuff. These are some of the responses that our patients also like. These are the things that our patients endorse as well as they come in the room and have depression, and that's what they say. That's just a deep sadness and hopelessness and feeling stuck, heavy weight on the chest, unmotivated. And so these are, and I'm going to use some of these to describe the criteria for depression. In psychiatry and in mental health, we use diagnostic statistical manual DSM-4. It's like a manual. It's sort of like the kind of like our reference to understand and diagnose mental health disorder. And so that there is a symptom criteria for depression that includes depressed mood, that includes anhedonia, which is decrease in trust in activities that they're interested in, or decrease ability to enjoy or participate in joyful activities. And so that's like unmotivation. And then there are other symptom criteria that will not really go into detail about, but still what you guys are bringing up are really the things that patients bring to the room and the patient's experience, regardless of what the symptom criteria is. But I'll just go and talk a little bit about depression, like what it is and how do we diagnose it in our in clinic. And so having depression, symptoms of depression most or nearly every day for at least 2 weeks, and that these symptoms interfere with one's ability to work or like sleep and study, eat, enjoy life, which is how it interferes with their social functioning, personal functioning, academic functioning, and occupational functioning. So the symptoms, sort of like per the DSM-5, that reference book that I'm talking about, the symptoms have to be there for at least for nearly every day for at least 2 weeks. The symptoms of depressed mood and anhedonia are really required to be present in order to formulate like a formal diagnosis of depression. So either they need to have depressed mood or they need to have anhedonia, which is loss of interest or pleasure in daily activities, for them to like fulfill or meet the criteria for depression. Other things are feelings of guilt, shame, like you guys brought up, hopelessness, or you brought up, decreased concentration, the cloud, you guys brought up, appetite changes, poor appetite, decreased energy level, decreased motivation, you guys brought that up as well. Poor sleep, you guys brought up that tired, like 24/7, that decreased energy levels, you guys brought that up as well. Sleep changes, some can have really like difficulty sleeping, some can feel like sleeping all day, so there are sleep changes. Suicidal thoughts, intent or plan, or thoughts are the thoughts, they don't really need to be there in order to meet the criteria for depression, but they can be present and are really common, and we'll be talking a bit about the prevalence here in just a minute. But before we go ahead, are there questions that we have? Can look into the chat box as well. Are there any questions? All right, so this is just like like an image that I just brought from, I got it from NIMH, and this is well like my mental health, and first determine how much your symptoms interfere with your daily life, like do I really need professional help or not. So situational depression, like the mild symptoms that have lasted for less than 2 weeks, feeling a bit down, some trouble sleeping, feeling down. Are there things that I can do? Do I really need help or not? If so, here are some self-care activities that can help, like eating, exercising, engaging in social. And I would say that, you know, sometimes it doesn't really matter if the symptoms have lasted for less than 1 week, or like have lasted even for like 1 day. It is really important that everyone has a different emotional capacity and reserves and have a different experience. So maybe for someone, their symptoms aren't, you know, are not really very incapacitating, but for someone, they can be. And it doesn't really matter if their symptoms are more severe or not. What is important is what the person is experiencing. And so I would say that it is, and NIMH is sort of like recommending that, you know, you can look in your symptoms, you can do self-care activities, and if your symptoms continue to improve, to continue to worsen, then you can like reach out to healthcare providers. But I would say, considering the times that we are living in the pandemic, it doesn't really hurt, and it's always good to like go and get the treatment and whatever resources that we have that are available to get the treatment before it's too late. I think the self-care activities are really important, and your role, hopefully as future mental health advocates, it's really important to kind of see what are the self-care activities, like what are the meaningful activities that one can engage in, what is restorative for one. Maybe something that is restorative for one is not as restorative for the others, but overall what NIMH is recommending are like exercising, engaging in social activities, whether virtual or in person, getting adequate sleep is important, getting a regular schedule, eating healthy, talking to a trusted friend or family member, or it could be a future LMHA like you guys, practicing meditation, relaxation, mindfulness. There's a lot of role of mindfulness that is out there. So those are things to kind of keep in mind. I've just like kind of broken that slide into like, when are we really advocating for patients and individuals to go out and seek help, seek professional help, and so if the symptoms last for more than 2 weeks. So these are like, they're going really about depression, because we mentioned 2 weeks, and if it's like for at least 2 weeks or beyond, then that's depression. But I don't think, as I said before, time frame matters, but it doesn't matter if the symptoms are so severe or they are perceived as severe by the person who's experiencing them. So again, difficulty sleeping, you're noticing the things that we talked about, like the depression slide that we were talking about, right? The appetite, the decreased energy level, the appetite changes, the difficulty sleeping, the concentrations. Now we are looking into the sort of like the criteria for depression and consolidating what we just learned 2 slides ago. And then whether the professional help that's available. So you as the LMHA would be looking into like what are the professional resources, like it can be psychotherapy, it can be talk therapy, it could be psychiatrist medication, it could be a primary care provider providing medications and so forth. And then in crisis, and we'll be talking about crisis shortly. Any questions about this? Prevalence. So this is depression, right? So depression, a thing about depression is that depression, according to DSM-5 and according to our training, what we have learned is depression comes in bouts. It comes in episodes. It's a distinct episode that lasts at least for 2 weeks and even more than that. And in that time period, they have depressed mode, they have decreased motivation, and all the things that we talked about, right? And we call that a major depressive episode. For a layman who doesn't have a lot of training in psychiatry, could think of depression as something that is chronic and it keeps going. And it can be true in many cases. And though we are able to sometimes detect a major depressive episode, sometimes we're able to identify it early on, and sometimes we can also work on relapse prevention for the next depressive episode, because for some, it can come in distinct episodes, get better, come again, get better, come again. And so what we know here from the data that we have, that's the most updated data that I could come up with, that I could find, because there were others that were more of a longitudinal data, but the SAMHSA website is a good place to get some epidemiological data, and NIH is also a good website for statistical information. So based on that, in 2017, they say, as you can see, in 17.3 million adults in the US had one major depressive episode. And then this number basically has been broken down, as you can see, based on ethnicity, based on sex, and based on age. I really tried to collect more data that was less gender conformed and more of like, diverse in terms of like gender and sexual orientation. I couldn't find, unfortunately, tons of data on that, but do have some data about the LGBTQ community that I would, LGBTQ population that I will bring up if we have time. But this is sort of like the data that we have got from here at SAMHSA, where you can see the prevalence being more in female compared to male, more in, as you can see, in the age between 18 to 25 compared to other ages. The important thing to note here is that how it is more prevalent, and you will continue to see the trend, because in statistics you notice a trend, and when you know that that trend is coming. And the trend here in mental health, especially depression and suicidality, is that in terms of race and ethnicity, American, Native American Indian have a higher prevalence of depression. And you would notice that the prevalence of depression is more when there are 2 or more races. Unfortunately, didn't get a lot of information on what were like the 2 or more races, but that's really important to notice that the prevalence is higher when there are 2 or more races, and the prevalence is higher in American Indian and American natives. That's the data to appreciate here. And then we go into the risk factors for depression. And so that's just like a normal kind of just an information out there, kind of factual based on data that we have, that there are so many risk factors for depression. You can have a genetic predisposition, a family history, personal history of a depressive episode, major life changes like trauma, stressors. They can also present with affective disorder and can predispose one to have and a depressive episode in future if they have been exposed to trauma and other stressors early on in their life, unfortunately. And certain physical illness and medication, that is sort of like a more kind of nitty-gritty details about what we know about certain physical illness. There's a lot of like neurological conditions and some other autoimmune conditions and some cancer that are really like neoplasms and that are really known to have an associated with depression. I won't go into a lot of details about it, but that information is there as well in the evidence. Treatment of, and I'm sorry, before I go to the other slide, are there any questions? I know that's a lot of information that I'm throwing, and so we can do it in a more peaceful fashion. We'll hopefully be breaking out into groups as well, so that would just allow us a little bit time to consolidate this information. Treatment of depression. Before I jump into, can just like any of you just just unmute and share with me, what do you think are the treatments for depression? Just of like broad. You don't have to be specific at all.
There's pharmaceutical and interventions and then different types of therapy.
Absolutely. Did you say pharmaceutical? Did you say interventions and psychotherapy? Did I hear it right?
Yes.
Oh, great. Yes, absolutely. Yeah, that's what I will be talking about. So first are medications, right? Lots of medications, won't be talking about it, but antidepressants, antipsychotics, and mood stabilizers. So just to kind of like, so just so you guys know, really in psychiatry, these are like the three kind of broad classification of medications that we have. And so antidepressants can also treat like anxiety, can also treat depression. Antipsychotics can treat bipolar, can also treat psychosis, illness, can also treat depression. Mood stabilizers can also treat psychosis and depression, and as well as like bipolar disorder. But it just depends on like why and like the choice, the rationale, evidence-informed care, evidence-based care, and patient-centered care. So we think about a lot of things while we're starting someone on medication. We kind of think about a lot of things and review the benefits and side effects and risk of like medications, because all these medications are not free from side effects. They are associated with some side effects. But antidepressants are the ones that are well tolerated, generally well tolerated. Ketamine infusion is like the new thing. There are just a lot of like research going on depression. There are a lot of hypotheses. What we know at this point about the neuro science of depression is based on hypothesis. Like there was a study that has just like a lot of concepts coming up about the role of ketamine, because there are certain receptors in our brain that are glutamatergic, and these ketamines are basically somehow they kind of lock themselves onto those receptors and block those receptors, and in turn what they do is they form healthy neuronal connections, and that is why they say ketamine is the new thing, and it can actually reverse depression. It can really treat treatment-resistant depression. So lots of studies and lots of research going on ketamine. Psychotherapy in layman terminology is talk therapy, and that ranges actually from anywhere from the cognitive behavioral therapy, where we do a cognitive reframe. We notice that patients with depression have a lot of negative thoughts, so we kind of help them facilitate it into positive thoughts. Then there's mindfulness-based psychotherapy, which tells a lot about, has a lot of like mindfulness-based approach, which is open, beginner's mind, acceptance-based, and non-striving-based, restorative kind of based therapy. And then supportive is like just being with the patient, emotionally present with the patient, establishing rapport, validating their emotional experiences. And so that there's a lot of data to support that medications in combination with psychotherapy is more effective than medication only and psychotherapy only. There's a lot of data on CBT in depression, and that's proven and is known to be effective and superior to medication only. brain stimulation, ECT, also known as shock therapy, and TMS, which is transcranial magnetic stimulation. There are a lot of like brain. These are called, the broad terminology is brain stimulation therapy or neuromodulation therapy. There is also a lot of research going on about TMS, which is because it's non-invasive, and ECT has a lot of stigma coming from, like, if you guys have seen movies from like really like from like remote, like, I'm not sure, but I've seen a lot of movies. I think one was like One Flew Away from Cuckoo's Nest or something, I forgot, but that really shows us a little bit about historical perspectives of ACT. ACT is done in a very safe manner now, but there are a lot of regulations, safety regulations implemented, yet it is known to cause some memory side effects and has a lot of negative connotation and stigma around that. But ACT to date is the most potent antidepressant that we have for major depressive or for severe depression, for really treatment refractory severe depression. Any questions about this?
So is the trick for TMS basically sticking electrodes in your brain and they excite the part in your brain that affects depression?
Yeah, so there are some more focused form of TMS where they can really put the magnetic probe and stimulation around some neurocircuitry that are known to be involved and implicated in depression. And then there is another one that is less focused, where they sort of like give a generalized treatment. There's more and more coming up, in fact, and there's more and more study coming up about its role in postpartum depression, its role in OCD depression, because of what we know about the neurocircuitry. It is known to be effective, but you're right, it sort of like stimulates certain areas and neural pathways or circuits of the brain. And that stimulation basically helps the stimulation of nerve cells in the brain.
Thank you.
Yeah, but it doesn't really known to cause like that really bad, like a very strong seizure that ECT would cause. It does something off that is similar to in nature like ECT, but I would say is less invasive and less kind of potent in terms of like the electric current that they pass is of lower, very, very lower magnitude as compared to ECT, which is very invasive. So yeah, so I was just thinking, because we talked so much about treatment, I was wondering if you guys have any thoughts about, can we do beyond pharmacological and psychotherapeutic intervention in depression? Any thoughts? Please chime in. Beautiful. Yeah. Oh, awesome. Yeah. We have like really, like I can see the future LMHA here. Oh, that's beautiful. Yeah, that's right. Right. Amazing. Supporting each other, understanding, supportive treatment, validation, building relationships, beautiful. Offering support, cultural support, beautiful. Advocacy, yeah. Yeah. Educating ourselves, yeah, I love that one. Raising awareness. Refer them to resources, absolutely. Encourage, yeah. Acceptance, that's beautiful. Acceptance is, yeah. Acceptance really helps with, and that's the paradox of mindfulness, where they teach acceptance, and in turn it actually helps with change. Yes. Oh, beautiful. Absolutely. Yeah. Listening, being empathetic. All right. Talking, understanding humanity. Beautiful. All right. I'm moving ahead. Linda, listening here. It's amazing. Yeah, so this is like all the things that are so important in what we can do. So that's sort of like different, we kind of like this is more of like what an individual can do, right? And you guys are bringing up what a community can do, and that's beautiful because that wasn't captured in this slide, right? This is about like what can we do if an individual is suffering from depression or a loved one do. So of course, like as you said, try not to isolate them. So offer support, lending a listening ear, being there for them, offering support, emotional support, spending time with a trusted friend. Realistic goals, I think it's really close to acceptance, right? Like we are really hard on ourselves, have really, really high unrelenting standards, and sometimes being realistic, having realistic goals really helps, right? Trying to be active and exercising. Yeah, I think that patients with depression tend to have very pessimistic, negative thoughts, and can have really strong feelings of like guilt, and can be very judgmental. So acceptance and realistic goals and mindfulness is really something that's key there. Spending time, expect their mood to improve gradually, not immediately. That was also something that one of you guys brought forward, is like understanding yourself. And so it's important to notice and also acknowledge that the depressive mood is going to improve gradually and not immediately. So having those expectations. Postpone important decisions such as getting married and divorce. I did not really think a lot about that. And when it came up, I thought it was really important to also share with my patients, like if they were making, because with depression comes ambivalence. Actually, it's one of the DSM-5 criteria as well. Like making decisions can be very difficult. Ambivalence is an important part that you'd see with patients who have severe depression would have ambivalence. And so I think it's a good idea to postpone like really important decisions in life. Continue to educate. Yes, great. That's amazing. Now we're coming into suicide, and I was wondering if we could just kind of take a 1-minute break. It's a pretty emotionally charged topic, so it's okay if you guys want to turn off your cameras or kind of mute, or like just go into a bio break for just 1 minute, and then we'll come back. And these are some responses from Talia, SSRI, and CBT. Question: what does treatment look like for people who are experiencing high functioning depression? Beautiful. Yeah, I guess for high functioning depression, again, it's like a spectrum, right? So this where maybe they are high functioning in one domain and low functioning in another domain. Maybe they are not having direct interference or significant impairment in their occupational and academic functioning, but what about their social functioning? So got to have a more broad and longitudinal assessment, and then discussing with them, right, whether you would benefit, kind of seeing how we tailor patient-centered care. Can we like really manage depression with self-care activities, with meaningful activities, doing something that's restorative, doing something that really aligns with their values? Or can we like refer them to talk therapy and have them speak with psychotherapists and psychologists for individual work, for CBT, which is more of like seeing them weekly and helping manage their depression just through talk therapy? And if that remains refractory, if the depression symptoms continue to persist, or refractory to weekly cognitive behavioral therapy or mindfulness spirit therapy or what have you, then considering to refer them to a psychiatrist for medication management like antidepressants. Did I answer this question? Okay, sounds great. Alrighty, we are going to get into this topic, and it's suicide, and that's really unfortunate. Before we kind of go into, I have like patients who are like suicidal and have attempted suicide in the past, and even for me, like talking about suicide is really loaded. It's a loaded topic. And so suicide is, we'll go into the definition to kind of help us understand what suicide is, because there's so many different definitions and so many different branches of it. So suicide is defined as death caused by self-directed injury injurious behavior, self-harm behavior with the intent to die as a result of the behavior. So there are different functions of a behavior, right? And injury to self could be it have a different function. And we don't know for sure. Sometimes it could be a function of like impulsivity, if they don't have a lot of coping skills, and what they know and what they have learned that is linked with our learning history is to engage in self-harm as a way of feeling pain or feeling something, or as an impulsive attempt because they don't have other more effective tools to regulate their emotions. A suicide attempt is a non-fatal, self-directed, potential self-injurious behavior with intent to die as a result of the behavior. A suicide attempt per se may not result in injury. It can, right? If they're overdosed or if they have like tried to cut themselves and have resulted in laceration or deeper laceration, and so many other to try to jump off the building and then had fractured their limbs, but it does not it is not suicide. Right. Suicidal ideation is the thinking, the thoughts. The suicidal ideation, another layman terminology, suicidal thoughts, refer to thinking about or considering to or planning suicide. And we will talk about it because suicidal ideation is then again has its own branches, which is suicidal intent and suicidal plan. But that is something that will not go into very much detail, as it requires a lot of like very formal suicidal assessment training. We'll do some of it within our context and within our responsibilities and role as a layman mental health advocate. I think prevalence, it's important to know the kind of prevalence, and that is from the CDC data that I had from 2018. That's basically the 10th leading cause of death overall in the United States, the second leading cause of death among individuals between ages 10 to 34, and the fourth leading cause of death among individuals between ages 35 and 54. So very serious. And from the most recent data that I found from NIH, which is not included here in the slides, basically says that the trends are going up. Although we don't have a lot of information from what is happening from 2016 onward to 2020, the trends are still going up. And I want to be very mindful in saying that I don't have a lot of evidence. There isn't a lot of evidence, and I couldn't find a lot of evidence to really support whether there is a cause and effect relationship between the pandemic and suicide. So we don't have that information. But I want to say the trends are going up, right, from 2016 onwards. Demographics, I think this is more of an information. I'll go into the let me see if I have more information here. The suicide rate among men were 3.7 times higher than women. And then among female, the suicide rate was highest for those aged 54 to 64. Among males, the suicide rates were higher for those at 65 and older. If I have a graphical representation, I think I will explain that better in that frame. And it's as I said, I wanted to bring up the LGBTQ and the mental health status disparities here. LGBTQ individuals are more than twice as likely as heterosexual men and women to have a mental health disorder in their lifetime. And also important to look at they're 2.5 times high risk of experiencing depression, anxiety. And if you look into the sexual orientation data and the considering attempt suicide, and this is the information I think from 2009, you can see the incidence and the prevalence of like them considering considering suicidal attempt is basically a suicidal intent or a plan and not like an attempt. And that is really high in the transgender population as compared to the heterosexual population. And of course, in gay and lesbian is more than heterosexual. Bisexual is even more, and transgender is like even more. That's the kind of very limited source information that I got. It wasn't in the STAMHSA website. And I think that more important, as we're talking so much about the mental health disparities and social determinants of mental health, that it's really important to like bring this data up. I like this data because it also gives us like kind of bifurcates the male and the female, as well as breaks down the ethnicity here. And again, as I said, like when you look into the data, you look into the trends, and for mental health disorder, you always see a trend where the mental health disorder, especially depression and suicidality, is more in the Indian American Native race, and regardless of the gender, as you can see here. And you'd also see that it is also higher now in the Pacific Islander. You can see the incidence of suicide rates, and these are not attempts; these are suicide rates. So this is completed suicide. And you come into look into the white male versus white female, and the risk and the prevalence is really high in white male. The other thing that is important to look at is in the data, you wouldn't see a big difference between the incidence of suicide in Black and Hispanic. As you can see, the population, it is pretty significant. And in both population, you'd see that there is a match there. And that is also a trend that you'll continue to see. So you go ahead. So always being mindful that individuals with American Indian descent, American Native, have a higher risk of suicide and depression. Alrighty. So this is just a kind of risk factor for suicide. I'm mindful of time. I just wanted to like look here and just without reading it, just kind of get a sense of like, what are the different risk factors for suicide? It ranges from individual, relationship, community, culture. And I want to point out that, yes, we talked a little bit about individual risk factors, mental health illness, other financial problems, impulsivity, right? Legal problems, serious illness, and so forth. Substance use is another important risk factor. With relationships, you can also see that past trauma, we talked about trauma, childhood abuse, adverse childhood experiences are a risk factor. Any trauma, bullying, family history of suicide is a huge factor. Community, it's really important to know that barriers to health care, mental health disparities, uneducated in or difficulties accessing healthcare is a really important factor. And there aren't a lot of like studies to really support that, but we do have some limited data to show that. Cultural religious beliefs can actually be protective. From this website, from the NIH, they basically said that there are certain cultural religious beliefs where they would say that suicide is a noble resolution. I want to bring up this topic because it's important to know that certain religious and cultural beliefs could actually be protective. Then there are like stigma that's associated with mental health illness, easy access to lethal means and firearms and medications. Psychiatric medications have the tendency, like if to sort of like really after a certain threshold, they can reach up to lethality doses, and some of the antidepressant could be more lethal than others. And so those are all the risk factors there. Let me pause a little bit and look at the chat. Okay, all right. Thanks. Yeah, thank you, Samara, for bringing this up. You want to talk a little bit about these points? The most obligational to cut or eliminate those biases. That's a great point. Yeah. Alrighty, so this is something that that psychiatrists and mental health professionals are trained to do. So I wouldn't really go into very nitty-gritty details about how we assess for safety and how we assess for suicide. But this is sort of like there are many different scales, but this is what we use here at Duke Emergency and in our clinics, and this is called Columbia Suicide Severity Scale, which is basically a question from like 1 to 6. And I just wanted to like, through this framework, just want to explain how the suicidality and the severity is sort of like considered in terms of like triaging crisis and triaging and assessing and identifying the risk of suicide. So basically, Usually, you know, the question one is usually, are you having any thoughts or like having any wishes? Like, is it like a fleeting thought or a wish that you were dead, or you would just go to sleep and not wake up? So that's sort of like the first question. That's how we ask. There are different ways of asking depending on the context. One could say, you ever feel like life's not worth living? Do you ever feel like you have, do you ever have thoughts of like ending your life, or wish like you weren't here for your family, or wish like you were a burden on your family and things would have been better if you weren't here? Or do you ever feel like you sleep and never wake up? So there are different ways of asking depending on the context, right? And then depending on what the response is, you sort of like built onto that and said, oh my gosh, this is, you know, validating how hard this is for them, and then having questions like, have you actually had any thoughts of like killing yourself, right? Have you ever had thoughts of like how you would ending your life? And so that would be more of like a question. Yeah, they can then, if they have thoughts of ending their life, that they can share with you methods or intent or plan of doing that. If they say, yes, we've had actual thoughts of ending our life and killing ourselves, then you ask questions about, oh my gosh, the past 1 month, have you been thinking about how you might do this? How might you act on these thoughts, right? And that would be like them sharing with you, yeah, like a method, like yeah, overdose, or like, you know, a firearm, or like, you know, jumping off the cliff, or like driving into traffic. It could be anything. And then once you have that, you then ask them like, have these thoughts that have you like, seems like these are very active societal thoughts of like killing yourself, like are you having any intention or like thoughts of how you would do that, and any intention of acting on these thoughts? Because these are, so first we started with thoughts, then we started in thoughts of like killing, then we thoughts of like how you would do it, and now are there any intention of acting on these thoughts? And then if they have like an intention, then you would ask like, okay, what is the plan? Are there any plans of like how you would carry out this in this plan, or any how do you intend to carry this plan? And then they will sort of like share with you the plan of doing that. And so that really is like the way of doing it, and there are very different ways of doing it, and we in our training are sort of like really trained as to how to do it. And then the sixth would be like, in the past few months, have you ever done, or in your lifetime, have you ever done anything to like end your life? And that could be anything from like collecting playbills to writing a will to loading a gun and putting their loaded gun in front of them, or like putting it on their head, and like aborted attempts, thwarted attempts, strangulation attempts, and so forth. And so you document that. So they are just, you know, they are here telling us about how do you triage it through low, moderate risk, and high risk. But in our training, it is very different, depends on their personal past history, and it is really depending on both the context, both their history, as well as a lot of factors are basically taken into account when we are triaging this. In any case, for you guys, it's really important to know that if there is a yes to any of these questions, regardless of like the severity level, they need to seek behavioral health counseling or crisis line immediately. That could be National Suicide Prevention Lifeline and other resources that we will be sharing with you shortly. Any questions? This is another, it's another screening tools, and there are a lot of screening tools. The one that we use at Duke is the Columbia screening tool. These are also some of the tools that are used in the ED settings. Mostly they all capture the same things, and that are basically kind of asking if they have any thoughts of like hurting themselves. This is in the past few weeks, which is less general, like less specific. That is in the past, I believe, 1 month, which is sort of like more kind of longitudinal, and getting a more sense of like a broader sense of like how they have been in the past few months and the past 1 month. But they're just almost, they're both screening. They're both screening tools. And we have a question: can the national hotline be anonymous? For patients have to provide personal contact information. They have to provide their information, because you know they could say anything and then you wouldn't know how to like help them. So the first thing that we do, and many of us in our trainings have been a part of like the crisis line at the VA. And so the first thing that we have been taught to say is like, please, can I have your first and last name? Can I have your last four? Can we please, we have the address that's pulled up, and can you please verify your address? And then we sort of like move on to that, because there have been so many times where, the wrong sort of like ways of doing would be like, oh my gosh, they call and they get all overwhelmed and sort of like endorse what they're thinking or endorse their suicidal thoughts, and then they hang up and we don't know where the call from. So it's something that is really part of our like learning, was like they always, and it has always been reiterated to us that always make sure their first and last name, their last four, their address before we launch into the assessment, safety assessment. Yes, that's a great question. So now the role of mental health advocates, and then we'll be talking about, and then we'll go into the breakout rooms. I think this is a great slide from LMHA, and basically this was not specifically for mental health advocates, but this was for like, what can a loved one or a person who is like their emotional support team could do for a patient who is in crisis, for an individual who is in crisis. What if patients refuse to give information? The hotline is anonymous. Rita, can you share with that? When you say anonymous, is it like they will not be able to give any information, like if they were in crisis? Can you talk a little bit about it? Because the hotlines that we have been in, we really have to have our patient for crisis text line. They don't have to provide any personal info until we ladder up to risk. Yes, so that is that could be for the crisis text line. In the crisis services that we provide both at Duke and at the VA, we have them share that information with us. I want to say for crisis text line, I don't know. But I guess Adeline is saying that they don't have to provide any personal info until we ladder up risk assessments. So it depends on like why they are reaching out to crisis. And thank you so much, Dahlia, for bringing this up. It depends on why they're treating crisis. If this is crisis, we want to help them. And so we want to give that and have that information. If this is emotional validation and they're going through a very difficult time, this is stressful, then I would understand why a personal information is not needed. Any questions about that? Simaro, do you have?
Yeah. So I would like to add that it is not required for you to provide your contact, your name. They're still going to listen out for you, but they will ask for it just to make sure that they can search out for you in case like you hang up or change your mind, or the person changes their mind. But in the end, that's just a person helping out, as you said before, like providing lending an ear to listen, and just to like kind of triage how severe this sounds and like kind of coach the person to get to the ER. But it's not like therapy that is given. It's not a dedicated time for the person to like vent out their things. It's a brief intervention that could take long, depending how long it takes for you to get to the hospital to take have your therapist call or something.
Yeah, right. I think what I am like really alluding into is like crisis, and I want to make sure that we all are on the same page when we talk about crisis, as we will be talking all about crisis management. So if it's a true crisis, and by crisis I mean that they're having active thoughts of hurting themselves and having suicidal thoughts, then that is maybe like ladder up risk assess is what Adeline pointed out, and that for that it's really important to get that information, or if we are not able to, then to have them at least go to the emergency or call 911, and that 911 would definitely require some information about the person so that they can at least send EMS, and that would be similar to like someone coding, or someone like having a stroke code, or someone having an STEMI and MI, that they would need treatment for that. And I want to make sure that we are when we're talking about crisis, we're talking about really taking these patients to seek to the emergency to seek acute behavioral health intervention. So the role of mental health advocates in crisis are like ask. And that is basically like, this is someone who is in active, not just emotional pain, but in crisis. And then the ask or the layman mental health advocate are then there. If they are the one who are providing support, they happen to be in that context, then they are thinking about killing. Are you like asking about, are you having thoughts of hurting yourself, as we mentioned before in our suicide assessment slides, then make sure that they have reduced access to like lethal items or place, like, you know, if they have access to like guns, then sort of help them secure it away, take that away, reduce access to like lethal items like medications that, you know, if they can overdose of them, like limit their access and prevent their access to those things, any lethal items or places. Be there for them, listen, as we said. That could be anywhere from like providing support, understanding, emotional validation, acknowledging their feelings. Helping them connect is like really important. So either save either the National Suicide Prevention Lifeline number, and seeing what they are gonna be doing, like, you know, helping them connect with National Suicide Prevention could also be like, do you have a trusted friend next to you? Could they help you bring you to the emergency? And so helping them and facilitating that process, even if it requires them coming to the hospital, being there for them during the time. Staying connected is very important, like following up with them after the crisis, not just that crisis is gone and it's okay. Following up with them is really important. There's a good bit of evidence to show that when patients were hospitalized for acute psychiatric illness or like depression or suicide, how did they do once they were followed up without medication and with medication? And there's a study that shows that when those who had contact actually did a lot better, having a lower suicide prevalence than those who had were no contact or were not on or refused medication. So there were 3 intervention arms, and the one with contact did really well compared to one with no contact. So no contact is it can have very negative outcomes, patient outcomes. So this is something that we just talked about. Helping them make a connection with a trusted individual and family member, spiritual advisor. So we all kind of talked about all these 4 important things. Again, studies have shown that a number of suicide deaths goes down when someone follows up with their at-risk person. All right, I think that resources are some of the things that I said that we would talk about. These are the National Suicide Prevention Lifeline, the Suicide Talk, and as I said, the calls are confidential. So whatever information this is confidential. That information will not be leaked. In terms of like them being anonymous, I think again there is a kind of triage where when can it be and how long can it be anonymous, and when do we need that personal information. Text hello, the crisis line, that basically any type of crisis, connecting them with a crisis counselor. And that when they say it can be any type of crisis, which could mean any type, from like very a difficult, stressful, and emotional, painful moment to like crisis, real crisis in terms of suicidal thoughts and ideations, intent, and plan, and so forth. The veteran crisis line is a line that Zumara and I have experienced in terms of like being on the toll-free hotline and speaking with the veterans and responding to their crisis in different ways. And so that is something that we have experienced in. So before we go to the breakout room, we would have someone read this case for us, and then we can go into the breakout room and then talk and share what the future layman healthcare advocates and what we will do, what our role will be in helping this colleague in a very stressful situation. We have a question. Okay. Yeah, right. Okay. All right. Can anyone just volunteer to read this case for us?
I can read it.
Thank you.
30-year-old male, been thinking of suicide all the time because he can't cope. Has a knot in his stomach, sleep and appetite are down, sleeps only 3 hours per night, and plans either to shoot himself, jump off of a bridge, or drive recklessly. He recently got divorced from his wife 1 month ago. There is a history of a serious suicide attempt. Patient jumped off a ledge and fractured both legs. The precipitant for that attempt was a previous divorce. Patient is tearful and feeling hopeless. He states that life isn't worthwhile. He shared these experiences with his colleague who is also a LMHA.
Thank you so much. Discuss and share how the LMHA can help his colleague in this difficult situation, can help them connect with the crisis resources. And so we will go into the, let's see, the breakout room here and talk about what we will do in this situation. I think we'll have like 7 minutes for a discussion, and then we'll come back and then have a post breakout room discussion.
Okay, everyone should be getting the notifications now.
Oh, we were yanked out of this really interesting conversation that I had, and Cristobal brought such important points, and so we'll be sharing all of those things here. But yeah, any thoughts, any things that you want to bring up in the post discussion? So go ahead.
I don't know if anyone's speaking. This is Donna. In reference, oh, I guess I could put my face back up there, but
Hi, Donna.
that in relationship to answering the question, our group came up with the importance of identifying that really taking an assessment to see how the crisis was. From there, we would be able to determine what resources would be needed and how would we react and be responsive. Because if he or didn't say yes to the pertinent questions, we would know, is really attempting in his time, even though he's in crisis, is it a mild or is it a major one, to call 911? One of the young ladies said, what if we were on the phone line and not there? How would we then handle the crisis? And it would be to, first of all, say to him, we would like to call 911, getting the permission, and then immediately doing what was necessary for safety, because we are looking at a safety plan to guard the life. So that's what we kind of talked about.
Those are so many, like, those are really important points, Donna. And I'm just going to break it down a little bit because you mentioned some really important points. First, about the suicide assessment. First, about like triaging this, right? That's like the first thing, the assessment. And the second is like getting the buy-in from the patient, right? Like, is this collaborative or not? And the third is like, what kind of resources based on our assessment? And I think those are really great points. And I think and Sarah has a great question, and I will address that as well. I think that for us, like our roles, again, we're going back to our roles and our boundaries and limitations, is that layman health advocates are their role is to connect patients with behavioral health experts. And so whenever they're sensing that there is a concern about safety or concern about emotional being, then they are like advocating and coordinating and facilitating the connection with behavioral health professionals, right? The suicide risk assessment that are basically being done by professionals, mental health professionals who are trained in doing this assessment. And even if there is any yes, regardless of like what the plan is, the intent is, the the thought, the urge, regardless of whether there is a fleeting thought, regardless of whether there is an urge, regardless of whether there is an intent, a plan, or a lifetime history of suicide, regardless, if there is a yes to any of these questions, these individuals need to be seen by a behavioral health professional. Now, that is basically kind of where we are and what our limitations are, right? That we, as layman health advocates, when we come across a colleague who's struggling with suicidal thoughts, intent, or plan, or what have you, or emotional pain, our job is to kind of explain like our role, like what's our role here. Our role of a layman health, a mental health advocate, is to help you coordinate and help you facilitate seeing a behavioral health professional. That's what we do. We facilitate that and getting the buy-in from them. It has to be collaborative, right? For this patient, they are reaching out to a colleague because of something, right? They trust a colleague. Maybe they need help. So asking and making it more collaborative, like, we're in this together. Thank you so much for sharing. This is so painful. I can imagine. And then also noticing, like, explaining our role, like, this is not something that this is something that I've been trained in. I help coordination. So sometimes it really helps the other person feel better, like emotionally more regulated, when they know that the person that they're talking to have some training and some expertise in coordinating care. And so sort of like, this is something that I've been trained to do. I really can help you in this. I want to see if you would be interested in collaborating. Let's do it in a collaborative fashion. These are some of the things that we can do. I can drive you to the emergency. I can call EMS if that was something that you would want, or then we can call the National Suicide Prevention Line together and see what the next steps are. Like in my experience, sometimes just going to the emergency can help get you care more quickly and more sort of like in a more timely manner. What are your thoughts? And then regulating our own emotions, right? Like, that is important. If we are feeling this urgency, right? If a layman health professional, a layman health advocate who's been doing this is feeling this emotional, is concerned, has this anxiety coming up, then that is an information in itself that we need to do something more urgently, right? So it is also important that we listen to our own emotional responses in this. And if you're sensing this is an emergency, because this case example is really towards like severity, like this is really severe. When you triage it, this is high risk. Then you can see, oh my gosh, I am noticing something that's happening inside me. This is an information. Let's do this really quickly. Let's get them to the behavioral health professional as soon as possible. So those are really great points. Thank you for bringing it up, because I was thinking of like going into that as well. And so those are great points.
Well, that was our group.
That's amazing. Xiomara, do you want to share something you want to ask?
I think one of the hardest questions that came up in my group was, what do we do if they are not willing, if they don't recognize that they need to go to get some help? I'm like, I don't think I've been in that situation. So it's hard. Like, you know, as you're saying right now, kind of levering, like getting in the same level, partnering up and like normalizing their reaction, trying to hear them out, and then offering like any assistance to facilitate things and clarify what's their fear. Why are they hesitating? Maybe, you know, like clarify myths and clarify like misperceptions, and like be honest that going to the hospital doesn't mean that you're gonna be admitted and you're gonna be in a crazy room, you know. That's right. In an asylum, you're gonna be evaluated, and if you have more protective factors than risk factors, then you might be able to go home, or maybe just stay one night there and like until things like calm down emotionally, and then just go home and continue outpatient follow-up. So it's not guaranteed that you're gonna be admitted.
That's right. Those are great points. And that, you know, as much of psychoeducation, normalization, as much of like really kind of helping them with validation, and also in some ways or the other explaining to them how it's going to be, how it's not going to be like that their perception as someone who is depressed has a lot of negative thoughts, and it is possible that they are sort of like catastrophic, having this catastrophic thinking that Shamara will be talking about in anxiety in a few minutes. But I guess it's important that our role, if we are having this feeling, which is really important, is that they may hurt themselves and they're in imminent risk of danger to themselves or other, even when we're not 100% sure, even when we're not 80% sure, and we're not getting any buy-in from patient, then we can always as a citizen petition them, right? And this doesn't mean like quote unquote like you a citizen. Any person who is thinking that a person is an imminent risk of danger to themselves and other can go to the magistrate and petition them. Of course, you would try to do as much collaborative care as possible, as much collaboration. But if that is not happening and you are seeing this person is an imminent risk of danger, then you can actually save their lives by petitioning them, which is sort of like the last thing that we want. But if that comes to that, then of course.
That's just like involuntarily committee.
Yeah.
Yeah.
So the petition, sending to the magistrate, and then they can then bring the patient to the emergency and then connect. Yeah, I think that this was really a great and very stimulating discussion that we had, and it was really like the meat of like suicide assessment.
Do you think you can talk a little bit about the importance of doing a warm handoff when you are someone has suicidal ideation and you have to transfer them to a crisis hotline or something, just giving them a number and being like, well, go call, I'll talk to you tomorrow, see how it goes, isn't as good as if you feel comfortable, let's maybe call them together and then I'll get off the line once you feel
That's really important. Like the importance of like transitions of care, because so much can happen from one emergency to another. You never know. A patient goes into one emergency and then gets transferred to another hospital. It's really important to be there, provide the information, provide their contact number. The LMHA can provide their contact information so that it is documented in their notes, so that if a psychiatrist or anyone wants to get some collateral information from them, they are there to provide that information. And also important to know, just from medical legal purposes, that the patient has actually given them the permission or getting that information from the patient, that they have a verbal consent to get the information from the LMHA. That's really a great point there, that it's important to share that information when you're transitioning their care. Sure, do I have to stop sharing on my end so that you can? Okay.
So let's take literally 3 minutes while we swap the screens, and then we'll continue, okay? Take 3 minutes to stretch out. All right. So let's try to get back to the computer and start this new topic. I am conscious about our time, so I do not plan to exceed our next 23 minutes. And to do so, I'll please ask to, make the questions, and maybe Hiva can help me out while I continue to do the presentation, but I'll try to address them at the end, just so I can continue with, with a linear thought. Otherwise, my ADHD won't allow me to finish my thought. Okay. So anxiety, yes, that's exactly what we do when we are under stress. We're just like in shock. Our bodies, survival instinct is making us think fast. So it's like analyzing the moment, the triggers, what's happening, and how we can get out of it. Wait. Okay. So right here, what we have is something that is called the hypothalamic pituitary system, or HPA axis, which is basically a chain of how hormones are liberated. Basically, when we have a stressor, our senses send the signal by of course the five senses, whichever of them are recruited, send the signal to the brain, and this and the hypothalamus sends a signal that we need to liberate more cortisol. And as we see, the CRA, this hormones activates the other, and in this ACTH activates the adrenal glands, which are on top of our kidneys, and then these glands secrete what is cortisol or steroid for us, that sends a signal to a couple of neurons that liberate norepinephrine, epinephrine, and other neurotransmitters that will help us to activate a sympathetic response, what is considered a fight or flight response. So I'm not sure how much you know about this, but let's say that we have either a sympathetic response or a parasympathetic response. When we eat, when we sleep, when we relax, the parasympathetic response is leading your body's whole physiology. But when there's a change in environment, something is new, we're learning something, we're under fear, or something that's attacking us, or we want to prey on something, and we can say it in any context. When we want to socialize or get the attention of something, our sympathetic system takes over. So when it does, then the stress makes sure that this cortisol gets to the organs in our body that will make sure that we can move, we can think fast, and that our heart beats faster, etc. So it's a whole chain. But why is it important? Why is it important that we are liberating this hormone? Well, this is related to our memory consolidation. So when, for example, seeing in this image, we may see a stressor. In this case, it says a snake, or you just put the name of whatever you're phobic to, or say that you're scared of an upcoming date, of a due date, or an appointment, or something, an interview, etc. And all your senses for 1 second, again, are enhanced. They're detecting what is environment, what is the temperature, what is the color, what's ahead of you, so you can remember that's, like how to escape from that situation in case you need it. So it goes to the thalamus, which is our receptor for our sensations. Then it goes to the visual cortex. Again, we're kind of creating an image of that moment. And then it activates our emotional system, which is centered in the amygdala. And by doing that, it stores in the hippocampus, which is another region in our brain that stores memory. So what creates a long-term memory, that memory that we use to recall content or to recall episodes, is a repetition of them. So how much we repeat it. If it's something that didn't caught that much of our attention and didn't liberate enough cortisol, it may just like go misperceived, and like you never recall, you will never remember that event in your life. But if it was something really shocking that kind of light up your senses and got some consolidation of the memory by this pathway, then you'll be able to retrieve that in the future, and you'll be able to know by what we say our instincts that this situation looks fishy, or I've been here before and I should escape it, or I've been here before and I froze and I don't know what to do. Okay, so I'm wondering, does any one of you know what different types of anxiety disorder there are? Well, I'll say there's one of the disorders that is specific phobia. So as it says, self-explanatory, you have something which you are pretty phobic. You see, and every time you see it, it just increase that release of cortisol in your body, and by itself it just changes your whole physiology to one of more being more alert, more aware, hyper aroused, and thinking fast, not thinking through, but thinking fast just to escape it or survive it. The social phobia, which is the phobia that comes with being around people, not just being within people, but talking to people, relating to others, and engaging in conversation. Then generalized anxiety disorder, which is like almost everything. Like that person that's always thinking ahead, oh, what if I fail this test? Or, oh, what if my car never, like, it doesn't turn on? Or, oh, what if I cannot pay my bills this month? So it's nothing specific, but they're always thinking ahead, frustrated, and kind of fearing of like the consequences, even if they're bad, but mostly they're in a negative context. Obsessive compulsive disorder, I am not sure if this was taken out from one of the anxiety disorders because of the mechanism. In the brain, it has a different mechanism from all these anxiety disorders that I'm explaining, and the type of mechanism that I just went through very broadly, very generally. But it used to be one of the anxiety disorders, and people with OCD tend to be harder to control and harder to treat just because that mechanism requires medication. It can be very severe. So I think I will not talk about this because again, it requires a different mechanism and is based on an intrusive thought from any kind of context that comes up, and you have to do something to undo it, and then it may be conflicting with your moral values and other thoughts, and then that's where the conflict comes in. So for that, you need both medication and therapy to talk things through, but again, has a different mechanism. And what we know as panic attacks or panic disorder. So panic disorder is when you have panic attacks 3 or more times within 1 week. So there's people who have it daily, which sounds awful. There's people who have it weekly. And again, we can diagnose someone with panic disorder when someone has it weekly. It doesn't have to like meet, a certain type, a certain number, but it depends on how it affects the person's functionality and social drive. So I want to make sure that we all know that anxiety is not always bad. So again, instinctively, primitively, we need the anxiety, we need this liberation of cortisol to make sure that we're capturing those moments and storing them in our memory for our future reference. Either they were really good and you remember really well, and whenever you like smell that perfume or like listen to that song, it gets you to that moment. Or maybe they were really bad, that lizard in the floor was awful and slimy and like ew, and you just don't want to say lizards again, otherwise you'll run backward. So it's important to know that there's a range. There's a range for anxiety where it can be good, beneficial, or it can just be too much, overwhelming. So as we see here in this graph, on the x axis we see the anxiety, and on the y axis we see the performance. So when we increase our anxiety, again, our performance may be inactive because we don't have a need to do something. Let's say we have a test, we're like, yeah, I don't have a test, I'm not even enrolled in college, why would I be anxious about this material? But then we do enroll, and then they tell us like in 1 month we'll have a test, and you're like, okay. So you're kind of like, about it, but you're not that stressed. And then 2-week mark comes up and you're like, I should start studying. It's like 3 chapters. And then you're like, okay, so you make a whole plan and you're like, this day I'm going to study 2 hours, and then this day I'm going to go to the gym, this day I'm going to go and you kind of plan things. So that's what's considered like an optimal stress. And again, we're seeing that the anxiety is ramping up, but the performance is getting to a plateau. It's like, we're doing what we have to do, what will be optimal for our development. And this can be transferable in any context, either like making your dishes, or like going to an activity, or joining a concert, or simply like talking with other people. You're like, I know I have to socialize, and then you're like, oh, tomorrow I'm going out with people. And then when you go out, or when that test comes up, the day of the test, or when you're there in front of the dishes to do them, you're like in the tipping point. You're like, I was thinking about this too much. I'm like, I'm feeling tired. So this constant rumination and going through what you have to do, constant planning and like thinking ahead, is just making your body feel exhausted. Because think again that you're liberating all that stress, all that cortisol that is making your body like waste all their energy just by just thinking. So you don't have to even be running. You just planification is make your body exhaust the energy levels. And then of course, if the anxiety continues to creep up, then your performance will be completely impaired, because you're going to be like, I cannot do this, I have to do now that test, and I also have to do 3 assignments that I didn't do because I was planning everything for this test, or I cannot do the dishes now because I also have laundry to do, but I was thinking that I don't want to do the dishes and now I cannot do anything. So everything just burns out, and you're just too overwhelmed. So when people come to us, usually to present to the psychiatrist, they're either in the orange zone or the red zone. I see more people on the orange zone because we're able to catch them faster, or they have other illnesses that we can, be concerned about their anxiety levels and like catch them without them presenting for that initially. But I would say when we medicate people with anxiety, either with pills or with therapy that can work as well, we try to get people to a yellow zone, because we don't want to have people like dozed up and drowsy and sitting. That's not the whole point. Anxiety, again, can be very beneficial. It's just making sure that you have a broader range that you can wax and wane within it without affecting your performance or overwhelming you or affecting your organs, because steroids fry your organs, literally. So I want to ask you all, how do you think a panic attack feels like? Mm-hmm. Mm-hmm. Yes. Yes. Mm-hmm. Mm-hmm. So what I'm reading is beautiful. I can also see how our sympathetic system is being activated. I can mostly check all of those that you guys have shared if I were to be on a jungle with a lion in front of me. Like, I will not be able to breathe. I'll be overwhelmed, suffocating, like maybe blocked. And I saw something having a heart attack, my heart pounding fast. Like, I'm thinking fast. I'm thinking how to survive. So let's say that when you have anxiety that is uncontrolled or a panic disorder, you're actually being thrown in a jungle there with this lion in front of you every single time. Can you work like that? Can you concentrate like that? Can you do something? Can you even engage in things that you actually love to do? And mostly, if you're like experiencing some phobia towards socialization or towards some sort of thing that's out there, like, are you even gonna get out of your house? So all the things you guys shared are pretty accurate. So you may feel like sweating, trembling, having your pulse go fast, being blocked, as it says there, anxiety. Like, you can interpret that in many ways. However, anxiety manifests in you. Your heart beats faster because like it's beating faster just to make sure that the blood is getting all over to your body and mostly to your brain. So it's like making all the job that it can. Also, that comes accompanied with the rapid pulse that we were talking about. So that's why you feel like everything's tightened up. You may feel nauseous because not a lot of blood flow is going to your internal organs. Most of it is going to your brain so you can think and act. You can feel lack of air again because you're just giving much attention to what's the next step instead of like your physiological and normal function. So I think it's important to know what is the percentage of the population that gets disability due to anxiety, because we say, oh, you're so anxious, and we use it trivially, but it's when it's diagnosed and you need medication for it and it really impairs your functionality, it can make you get disabled. It can make you be like a 40-year-old person acting like an 80-year-old who doesn't want to go out, who doesn't want to meet new people, who doesn't want to eat new food because they may think it's like it may make them sick, or they're anticipating that something's going to go wrong. And then that person can limit themselves. So getting them out of that disability, like getting them back to their routine may be super hard if we don't catch this on time. So, okay, I think, of course, there's one that's pretty close. So the percentage of population that gets disability here in the nation is at 23%, 22.8% of people. So that means that by every 100 people that goes there to work, 22 people are just at their house with that check that comes in monthly because they cannot go to work. And we say, but can we just like treat them medically and like get them back? I don't think it's that easy because that percentage is for severe anxiety. For moderate anxiety, which I think is treatable, it's a 30%. And then for mild, is very low. So once you've learned, as I explained in the beginning, once you've learned that this setting or this conglomerate of things, like either the music, the flavor, the smell or something, it's attached to something that happened really bad, you won't be able to go back there and experience again because you're so afraid of experiencing the heart beating, the intense sweating, the numbness that you like went through, that you won't be feel as adventurous to experience it again. And that is why you just get, the anxiety progresses instead of like getting better. Okay. Treatment for anxiety. As Hiba discussed before, we can give medications. Usually antidepressants work really well. If they give you SSRIs, that someone mentioned earlier, it's great because that is the molecule that doesn't make us happy. That is the molecule that makes us more adventurous. So if you were kind of blocked before, but now you have increase of that neurotransmitter that will actually make you go a step further, you actually feel accomplished and you're like, hey, I'm a step closer to X, a frightening experience. You're like, huh. And then you'll feel like more adventurous to give 2 more steps and so on. So it's a gradual process. It's nothing like you take the pill and you're like, oh, I'm fine. I'm not anxious. It's nothing like that. That pill will be benzodiazepines. And we would only give it when there's objective data, like vital symptoms that are unstable or like are really bad impairment in their functionality in their lives. If people are not eating or drinking, doing the basic things because of the anxiety, because the benzodiazepines in the long term are not good. They're just like taking a Tylenol for a fever when the cause of the fever is an infection. You're not killing the bacteria with the Tylenol. You're just curing the fever, but the infection is going to get worse if you don't treat it with the adequate antibiotics. So it's basically that same concept. You need an antidepressant, which / anti-anxiety medication that'll regulate that pathway again and those neurotransmitters in your brain, and the neurons will be able to fire again. And then by experiencing the things that you stopped doing, you'll learn again how to do them, and you'll become the functional person again, instead of just taking a benzo, numbing yourself down, sleeping it off, and avoiding the trigger or avoiding the experience. I put them out here. The benzodiazepines were considered to be the short term. Now we don't give it as easy, and there's many other ways, coping mechanisms, apps. You guys, the advocates, who will be available to provide like validation and support to these people who are on a crisis or during a panic attack. And of course, psychotherapy, kind of navigating and restructuring that cognition. So whatever you learned that was really bad, understanding what's your behavior after it, or once you experience it, and trying to restructure, like how can we change how you react to this trigger, and then you make sure that you're able to just face it without actually getting that distress. But all of this takes time. Anxiety is not something that it's cured within days. So how can we support someone instead of being hurtful? At times we just want to, okay, I'm here for you, but there's people who really want you to feel better, and they're pretty well-hearted, but they just say these things like on the left side, oh, it's not worth worrying about it, or everyone has it, don't worry, you just have to deal with it, like, oh, get over it. Or have you tried yoga, meditation? They're like, oh, you're just stressed, it'll just go after you're done with this event, it'll just go. So I think those ways were very subjective and judgmental, because they're putting their impression of their perception of the trigger or event that, of course, does not cause the same reaction that causes to you. So it would be better if that person who's helping you out would say something like, how does it feel for you? What do you feel? And then they can navigate it, talk openly about it, and be like, well, when I experience this, it's this and that. I feel this way, and I find relief in doing this and that. And they'll find their answers by themselves. They know what to do. They're just blocked for that 10 minutes. So asking these questions like, is there anything I can do to help, which is open and not judgmental? That sounds tough, validating that what they're going through is rough. But then like, you're doing well. Look, you were able to actually stay here and not run to your car. Like, oh, okay. And that's just like kind of positive reinforcement for the person. You can also offer, like, as it has been said a lot of times here, like offering that ear, lending that ear to listen to the person's thoughts and like fears, preoccupations, and then like, you know, making sure that you can provide reassurance to the person. Hey, you've done a lot, and you're doing really good. Let's see how else we can help you. And if you have to make the call and make that appointment for that person, do it. There's nothing wrong. Of course, get their information and get their permission. But again, like partnering up and being open about statements and not judgmental, it's the key. Yeah, I think I went through anxiety. Is there any question? Now, let me open the chat. Yes, benzodiazepines also have addictive potential and can be found in it. Love it. Okay. Are there any questions?
I will say, just before we end, I do want to show everyone how to access the video recordings, which are usually uploaded about a day after we complete the classes. So here's the Layman's Health Advocates website. You click on classes, you click on lectures, and it will show you the tabs for the PowerPoints and the recorded lectures. So that is it for me. Thank you guys.
Thank you guys, and feel free to share my email if you guys have any questions and need further guidance. We're here to help, and like, of course, this is a very nice thing that you guys are doing, providing assistance and like partnering up with people who have psychiatric illnesses. So thank you.
Thank you.
Thank you.
Yeah, feel free to reach out. Yeah, and for any questions, and thank you so much everyone for participating, such an active participation. Thank you.